All right, let's jump right in. Today, we're going to break down the most common sustained arrhythmia you are absolutely going to see in your clinical practice, atrial fibrillation. Seriously, you will see this constantly, whether you're on the wards or in the clinic, so let's get you ready to manage it like a pro.
Okay, let's kick things off with a number that should really grab your attention. What if I told you that for literally anyone over the age of 40, there is a 1 in 4 chance, a 25% lifetime risk of developing this condition? That's the staggering reality of atrial fibrillation, or AFib, and it's exactly why understanding it is non-negotiable.
So, what is this thing really? Well, at its core, AFib is just electrical chaos in the atria, the top chambers of the heart. Instead of a nice, coordinated squeeze, they just kind of quiver. This disorganized mess of signals gets sent down to the ventricles, all haywire. And that's what causes that classic irregularly irregular rhythm you'll see on an ECG. So here's the game plan for today. First, we'll nail down the basics of AFib. Then, we'll walk through diagnosis and the initial workup. After that, we'll talk about managing an acute episode, cover the absolutely critical topic of stroke prevention, and wrap up with the great debate, rate versus rhythm control.
All right, first up, let's really dig into what atrial fibrillation is, and more importantly, why it has such a huge impact on our patients' lives.
So, why do we get so worked up about a slightly shaky heartbeat? Well, because the consequences are incredibly serious. First and foremost, AFib comes with a staggering 5-fold increased risk for stroke. And it doesn't stop there. It's a major player in heart failure, it's been linked to dementia, and if you let it run too fast for too long, it can literally wear out the heart muscle, leading to something called a tachycardia-induced cardiopathy.
It's really helpful to think of AFib not as a single event, but as a progressive disease, a continuum. It often starts out as paroxysmal, meaning it comes and goes on its own. But over time, it can become persistent, hanging around for more than a week. Eventually, it can become permanent, which is a clinical decision where we and the patient agree to stop trying to get back to a normal rhythm. Knowing where your patient is on this timeline is key.
Okay, let's move on to the practical stuff, diagnosis and workup. You suspect AFib. How do you prove it? And what are the essential next steps you need to take? The diagnosis really begins and ends with the electrocardiogram. You're hunting for 2 classic signs. No clear P waves, instead you'll see these chaotic little fibrillatory waves, and an irregularly irregular R to R interval. That total lack of a repeating pattern between the heartbeats, that is the dead giveaway for AFib. So, you've got the ECG. Now what? You need a systematic workup, and it boils down to 4 key steps. 1. Get that 12-lead ECG to confirm it. 2. Do a deep dive with a full history and physical. Look for things like high blood pressure, diabetes, sleep apnea. 3. Check some key labs, especially a TSH, because an overactive thyroid can actually cause AFib. And 4. Get an echocardiogram to look at the heart's structure and function. Okay, next section, managing acute AFib. Picture this, a patient just rolled in with new onset AFib. Heart rate is flying. The clock is ticking, and the choices you make in the next few minutes are absolutely critical. Before you even think about which drug to grab, before you do anything else, your entire approach hinges on the answer to one simple question. Is the patient hemodynamically stable or unstable? The 2 paths forward are crystal clear. An unstable patient is showing signs that their body is not handling this well at all. We're talking low blood pressure, chest pain, or signs of acute heart failure. The action here is immediate. Urgent electrical cardioversion. You shock them. But if the patient is stable, you can breathe. You have time. The goal shifts to just controlling the heart rate and figuring out what's going on. Let this clinical pearl burn itself into your brain. If you remember only one thing from this section, make it this. A patient in AFib who is unstable needs electricity. It's one of the very, very few always answers in medicine. Let's shift gears now to what is arguably the most important part of long-term AFib management. Section 4. Stroke prevention. This isn't just about the heart. This is where we save brains. So why does AFib cause strokes? Well, because that quivering atrium lets blood just sit there and pool, forming clots. Those clots can then get pumped up to the brain. To figure out who's at the highest risk, we don't guess. We use a validated scoring system, and our go-to tool for this is the CH2DS2 VASC score. Calculating this score is pretty straightforward. You just go down the list. You get 1 point each for congestive heart failure, hypertension, diabetes, vascular disease, being age 65 to 74, and for being female. Now, you get 2 points for being 75 or older, and 2 points for a prior stroke or TIA. As a general rule, a score of 2 or more for men, or 3 or more for women, means you should strongly consider anticoagulation.
So when we decide to pull the trigger on a blood thinner, we have choices. For most folks with what we call non-valvular AFib, the direct oral anticoagulants, the DOACs, are the way to go. They're way easier to manage than warfarin. But, and this is a huge but, you have to remember that warfarin is still mandatory for patients with mechanical heart valves or significant mitral stenosis.
All right, we're on to our final section. Let's tackle the big, ongoing strategic debate in long-term AFib care. Section 5. Is it better to control the rate or control the rhythm?
First things first, you've got to get the heart rate under control for pretty much everyone. A rate control strategy basically says, okay, we'll live with the AFib, but let's slow it down. For your patient who's feeling fine, a lenient goal, keeping the resting heart rate under 110, is usually enough. But for someone who's symptomatic, feeling palpitations or shortness of breath, a stricter goal of under 80 is probably better.
But what about actually trying to get the patient back into a normal sinus rhythm? For a long time, we thought it didn't really matter. The big trials showed no benefit. But that whole conversation got turned on its head by the landmark East AFnet 4 trial. It showed that for certain high-risk patients, trying to restore a normal rhythm early in the disease actually led to better outcomes. A real game changer.
So who are these patients? Who should we be thinking about for a rhythm control strategy? Well, the evidence points to a few specific groups. Patients who also have heart failure, those who are still feeling symptoms even with a good heart rate, younger patients, and folks who've had AFib for less than a year. The takeaway here is that this decision has to be personalized for each patient.
And listen, a rhythm control strategy isn't just about pills anymore. Catheter ablation, which is a procedure where we go into the heart and electrically isolate the trigger spots for AFib, has become an incredibly effective therapy. In fact, it's proven to be more effective than antiarrhythmic drugs and is now considered first-line therapy for some patients, especially those who are younger and more symptomatic. And that really brings us to what's next, a huge question that you are going to have to grapple with in your careers. With smartwatches and all these wearables picking up short asymptomatic bursts of subclinical AFib, a whole new challenge is popping up. What do we do? How will we manage an arrhythmia that the patient can't even see or feel? That right there is the next frontier. Thanks for tuning in.